Hello, it's my pleasure to share an overview of international antimicrobial resistance, or AMR, surveillance. This lecture is meant to be a complement to some of the other lectures in the series for a digital health hub. So these are the National Action Plan and also UK-based surveillance in human health and animal health, as well as in the environment. The learning objectives of this lecture are to describe the complexity of AMR surveillance, specifically taking a One Health approach and thinking about digital health, to share some examples of international AMR surveillance systems, and to reflect on challenges and opportunities in the context of digital health. Antimicrobial resistance is a complex global health issue, and it's really important to take a One Health approach to this really important problem. There is a wide interaction between human, animal, and environmental factors that help the spread of antimicrobial resistance. Some of them are listed here, and we are just starting to understand some of these, to be honest. So that is really why surveillance systems are extremely important. I'm not going to be able to do justice to the many surveillance systems that exist out there, and I'm not going to evaluate them specifically, but I invite you to look into these guidelines that were published quite a while ago in 2001 by the US Centers for Disease Control and Prevention, and these are guidelines to evaluate public health surveillance systems. So there are recommendations that I have found very helpful. That go through a checklist of different tasks. So first, gathering the different list of stakeholders, people you would like to engage with, thinking about your surveillance system and the reason why you're looking into that surveillance. What do you think this surveillance system was set up for? Is this to evaluate an intervention? For example, if you'd like to look at the impact of a vaccine that is being introduced in a new country and you're looking for conditions, are you looking for the clinical progress of certain clinical conditions? Are you looking to evaluate the cost effectiveness of different interventions? So there's many ways of looking at that. And again, mentioning the One Health approach, there's many ways to look at AMR and this complex problem. So this gives us some guidelines in terms of what to look for within the system, the data robustness, whether it is a flexible system, for example, if there are new case definitions that are involved or new diagnostics that are introduced in the middle of the surveillance system, will those be affecting the quality of your data? Finally, focusing on the evaluation design and what you'd like to look into specifically for your surveillance system, putting the data together, sharing recommendations will be the most important steps. These guidelines were updated in 2001 to address some of the new ways of working and specifically the electronic exchange of health data. So that is good news. Although they are many years out, I hope you will still find some usefulness to these. Antimicrobial resistance needs a concerted approach, and in 2015, WHO member states agreed unanimously to publish this global action plan, and it had 5 objectives. First, to improve the awareness and understanding of AMR, and this is typically through education and training and communications. To strengthen the evidence base through surveillance and research, and this is what we're going to focus on. So this is one of the 5 objectives of the Global Action Plan. To reduce the incidence of infection, typically through improved hygiene and infection prevention and control practices. To optimize the use of antimicrobial medicines in humans and in animals, and that is typically called antimicrobial stewardship. And finally, to develop economic sustainability and business models and increase investment in new medicines and other interventions such as vaccines and new diagnostics. So our collaboration with industry here is primordial. Really important to keep a global approach in this. Interestingly, in this global action plan, which was published in 2005, there was no mention of digital health. However, in WHO's global strategy on digital health, which is still ongoing at the moment until 2025, this has 4 strategic objectives. And strategic objective number 1 is specifically about collaboration and knowledge transfer and has a target impact to have increasingly appropriate and sustainable digital health ecosystem. So we are still thinking along the same lines, which is great. I'm going to focus on one public health surveillance system for a moment. This is WHO's Global Antimicrobial Resistance and Use Surveillance System. So as its name implies, it monitors both antimicrobial resistance within pathogens and use of agents against those infections. There are some examples of what you can find in the report, and I invite you to look at it into more detail. There's also some very nice data visualizations on the website. So I have listed a couple of examples here. For example, you can look at the data by pathogen. So a drug-bug combination here, you have ciprofloxacin against Salmonella. Also chronic conditions are listed. So things like bloodstream infections, gastrointestinal infections. And as we will see in most countries, gram-negative bacteria are really at the top of the list in terms of concerns with AMR. On the antimicrobial use side of things, looking at the total consumption of antibacterials, so this is the WHO ATC classification, and comparing the diversity and the type of antibacterials that are used from one country and region to another is very helpful. Obviously, this needs to be correlated with the local AMR, but it's a good start in terms of trying to explain some of the regional variations and pinpoint some opportunities for intervention. There are many different tables in the report. This second table that I'm showing at the moment, and you don't need to focus on the details, but basically has 3 colors, even though you can't see the red very well. But there's green, yellow, and red for the 3 aware categories that WHO has listed for classification of antibacterials. So this is access, watch, and reserve, depending on whether an agent is broad spectrum or narrow spectrum as much as possible, whether it has toxicities, and what are their potential for antimicrobial resistance when used. So there's a lot that can be talked about for this categorization, and every country is dealing with this in different ways, but originally this was specifically for countries to make sure that we agree on a list of antibacterials that should be accessible in all countries. It is also being used to look into the appropriateness of antibacterial use, and the WHO has a recommended target of 60% at least of antibiotics used in a country to be of the access category, meaning the narrower spectrum and the less toxic and less opportunity for AMR on the long run. So these are all in the report. It's important to note that GLASS offers a standardized approach to data collection, but there are limitations for this. They try to mitigate that by using a number called the testing coverage, which looks at the microbiologically confirmed infections with availability of antimicrobial susceptibility testing per million population per country or territory or area. So as much as this is done, you can imagine that there will be variation within country, but it's good to be able to compare like to like. This is a map of countries and regions and territories that have signed up for the system. For AMR, this is 116 areas by 2021-2022, and 79 for GLASS AMC, the antimicrobial consumption component. So as you can see from the geography, there's going to be a wide variation in terms of resources that will be available to countries and possibly affecting some of the metrics. So things to take in consideration when we're looking into the results of surveillance systems. Glass also has a very lovely data visualization dashboard, and I invite you to take a look on the website. I show here one map that you can look at. You can play around with the years, with the type of infections. For example, this is bloodstream infections, the type of bacterial pathogen. This is for Acinetobacter, and so on. So some really nice interactive tools to look at the data in different ways. Glass works in collaboration with different regional networks. CSER and EARSnet are two of the ones that the UK have been involved in. There's also the Latin American network for surveillance and the Western Pacific regional AMC surveillance. So lots of colleagues to collaborate with. I invite you to look at the report on AMR surveillance in Europe. This is a collaboration between ECDC and WHO for countries who were not within the EARSnet remit. Finally, a quick word about point prevalence surveys. So these are types of snapshots where data are collected typically at a specific point in time, which is the reason why they have to be repeated at regular intervals for people to be able to benchmark and compare trends with time. And they typically, so depending on where countries and regions are doing these, there's obviously some global ones, regional ones, and national ones. They can focus on healthcare-associated infections, on resistance, on antimicrobial use, but they have this really nice ability to be able to give more details depending on the data collection tool and the amount of resources that can be put into the point prevalence survey. So this helps us understand sometimes the appropriateness of antimicrobial prescribing, which is not very easy to collect through routine public health surveillance systems. So this is one way where countries and states are measuring AMR. An example here is India, who have published their first multi-centric point prevalence survey. This is for 2021-22, and some accompanying communications within the media. And so that's a really nice way to engage with the wider population and with policymakers once you have those data and are able to compare trends through time and again with other states. So these point prevalence surveys are very resource intense. It is really important to think about ways we could do this better. And I do think that in terms of digital health, with better automation of the data collection, we have an amazing opportunity to not necessarily rely on very tailored and labor-intensive data collection, but rather have some more passive ways of receiving the information and make it more meaningful. Another example here, we're still talking about human health and a single country, so antibacterial resistance in China. This was published in Clinical Infectious Diseases in 2018. And surveillance, again, as indicated in the China National Action Plan in 2016 to 2020, you'll notice that a lot of the national action plans date around the same time. So really just after this 2015 global galvanization of efforts. So it speaks to the power of some of these international fora and discussions in terms of consequences and actions. So this looks into two established surveillance systems. There are actually many different regional, local, and national surveillance systems in China. And these two were founded in 2005, so before the action plan. But at the same time, this was a good opportunity to get the results together and share them for wider awareness. So the China Antimicrobial Resistance Surveillance System is one of the two most commonly referred to. It has over 1,200 hospitals from all provinces and regions. 75 of these hospitals are tertiary hospitals and 25% secondary hospitals. So again, thinking about the surveillance systems and the possible biases and reporting and what we are measuring is really important. In 2016, they reported data for over 2,727,000 bacterial strains, so a huge amount of really important information. Similarly, the China Antimicrobial Surveillance Network is a network of less hospitals, only 34, but at the same time, it has a really nice representation, including children's hospitals, 25 provinces, and a total population of 960 million. In 2017, there were over 190,000 bacterial strains that were reported. So you'll see on the right side that Staph aureus, and specifically methicillin-resistant Staph aureus, or MRSA, is a particular problem in some provinces in China. And there's also some reports of gram-negative, specifically Klebsiella pneumoniae, where carbapenem-resistant Klebsiella pneumoniae increased since 2005. So some concerning reports from here that are not dissimilar to what other countries are reporting. Another way to compile the data is through this beautiful academic base, but also several public health and major stakeholders involved in this huge effort to measure the global burden of bacterial antimicrobial resistance. So this is through a systematic analysis. And these researchers have looked specifically at the DALYs, the disability-adjusted life years, that are attributable or associated with antimicrobial resistance. So this is perhaps a more meaningful way to measure antimicrobial resistance and say how much it affects our health and our lives, again, staying in human health at the moment. I think this is really helpful to think about. You can read the report in full, but I think it's really interesting to think about not just the number of infections that could be prevented, but I think we need some better economic analysis in terms of the cost of AMR. That is very difficult to define. It's very difficult to find a model that will also take into consideration some of not just the direct burden of resistant infections, but the fact that we are losing options in terms of antibiotics and how this affects our modern healthcare. So, for example, when we think about the number of C-sections that are done, cesarean sections, or routine surgeries, hip replacements, or even chemotherapy that we're giving to patients, these all rely on the fact that we have antibiotics that are safe and effective. And sadly, that list of antibiotics is growing smaller, and the pipeline of new antimicrobials is not catching up at a fast enough rate. So things to keep in mind, and I really encourage some more similar measures of the burden of resistance, and I understand that this specific analysis is being brought up to date at the moment. Now, a very good example of a One Health approach is from Canada. This is an example of their data flow. They bring in data from private laboratories, public laboratories, also veterinary laboratory, and they will be looking into use and also other sectors such as agri-food and wastewater. And I'm really hoping that more and more countries will be taking up their challenge and having similar efforts, because this is definitely a need that is not addressed well enough, I believe. Some other examples here are Thailand's integrated One Health surveillance, a report that was published just a few months ago, and same thing for the third UK One Health report, which will share some of these data. Finally, some reflections on challenges and opportunities, specifically in the context of digital health. As we've mentioned already, the appropriateness of comparisons and making sure that we are not comparing apples to oranges, I think is important, thinking about the metrics and the way case definitions are agreed on. Coordination and capacity building. So the coordination itself is just a huge amount of work. There's a lot of information governance that needs to be put in place. There's concerns about privacy, confidentiality of data, data sharing, and I think that is definitely an opportunity specifically for multinational collaborations to enhance the way the data are collected at the moment. In terms of capacity building, as you've seen, different resources may be allocated to different public health systems, and I am hoping that digital health will help us put people at the same level in terms of catching up with some of the electronic reporting, especially for places where there aren't as many resources in terms of human resources of people going around hospitals, for example, and collecting data on pen and paper to be able to report through public health surveillance systems. And with the advances of electronic health records, I think that's a specific opportunity for some more public health surveillance to be acquired in routine ways, as long as this is done, again, with the appropriate governance processes. Finally, my last call for global collaboration. As we've seen, many countries have been taking forward their efforts after the 2015 discussions, and I'm hoping we will have similar collaborations at the UN high-level meeting, which is scheduled in September 2024. So this is a high-level meeting on AMR specifically. I think some specific topics that need to be discussed are collaboration, not just multinational agreements specifically for data sharing, but also thinking about collaboration with industry and inviting them to look into new antimicrobials, new diagnostics, and ways to address antimicrobial resistance. I invite you to look at the references I've included in the slides for more reading, as well as some outputs from the Fleming Fund. There are some really good description of AMR surveillance work that is being done in African countries. And finally, some more reflections on resource-limited settings and laboratory informatics capacity. The links will be in the slides. Thank you very much.